So we're going to talk about lower back pain generally today, covering all sort of aspects, sort of seeing what we've all experienced within clinic and any tips and advice. So who wants to go first about back?
Yeah, I mean, I'll expand. It's as generalised as you're going to make it, isn't it?
That's exactly, yeah.
Yeah, I think one that always creeps out is the good old sciatica, where people come out, I've got sciatica. It's like, well, what is it? You know, it's a huge umbrella term that covers numerous different pathologies. You know, but people understand it because it's a buzzword, it's in the media, you know, all this type of stuff. So I've got sciatica, but the key with anything like that is identifying the actual root source of the problem, whether it's a disc issue, whether it's a facet joint problem, whether there's a bit of sort of muscular tension somewhere that's contributing to it, or if it is an actual neural pathology that needs further investigation. You know, I think with back pain, again, I don't know if there's a stigma behind it, but for whatever reason, when people get any sort of back issues, they just down tools. It's like if people have a bit of a niggle in the knee, I'll be all right. I'll cope with it. I'll be all right. A bit of rest. I'll be saying. But with the back, they just sort of, whether it's a panic or what, they just down tools and go, oh, I can't really think in case my back goes. My back's a bit stiff, my back's a bit sore. And the amount of times you try and discuss it with people, that your back is so much more robust than you actually think it is. It can cope with so much more load than you actually think it can. But people sort of work in reverse. They get a bit of a tweak. They guard it, so they get weaker and weaker and weaker. So the ability for the back to cope with load then gets less and less. So then there's actually an issue that arises. But I think a lot of back pain, a lot of dealing with back pain is what we constantly talk about is education to people. You know, educating them on what it is, how it's structurally put together, what the pain is you're experiencing, why it might be. And a lot of the times, to be honest, with back pain, it's good for us to understand the potential diagnosis, but ultimately they don't really need to know it because it panics them a lot of the time. Do you know, when you have these big long words, if you come out with ankylosing spondylitis, it's like, oh my God, I'm dying. Do you know? And it's like, really, you're not. Do you know, like we can cope with it. Do you know what I mean? Or you've got a disc bulge, or Bob down the pub had a disc bulge, end up in a wheelchair, different person altogether. Do you know, it's just educating, and a lot of the time it's just sort of reassuring people that it's not actually the end of the world. We can deal with it. There's plenty of things you can do to help settle it down. It's just understanding the process to go from where we are now to back to fully fit. And a lot of that is characteristics of the person that's sat in front of you. You know, the job, the lifestyle, previous history, previous surgeries, whatever that might be, is understanding all that to then put an efficient process in place or proficient rehab in place to then.
And it's doing it at the right stages as well, isn't it? And also, like, going back to like your discologies, you get people, I've got a disc bulge, or I've never been able to do that anymore because I had a disc bulge when I was 20. And how old are you now? 46. So you've not still got a disc bulge then? What do you mean? And it's like, it doesn't mean that you have a disc bulge and it's always that way. And also the sort of, like you say, your spines are so robust, they're not weak, and those analogies that they used to always go on about the cringiness, like your disc is like a donut, and if it's squeezed the wrong way, all the jam will come out. When it's like the more sort of common analogy that's more realistic is like it's actually real tough, like tire, and if anything, yes, it's got a squishy substance, but it ain't leaking out unless something really, some big force. Scientifically, it makes sense. Is it squishes it that much, or, you know, all these other factors. It's not just going to happen just like that.
In terms of reassurance, a comment I generally use quite a lot is try and sort of really dumb it down. You've got sort of two incidences. You've got a really strong, acute, instant lower back pain where someone picks something dead simple off the floor and bang, the back's gone. And it's rip-roaring agony. And you've got the other side of it where you've got this sort of chronic disc issue. If we're sticking on discs, you've got this chronic disc issue that sort of slowly grumbled on for a while, and it slowly sort of raised its head from years of sitting behind a desk, and all of a sudden now we've got a bit of disc pathology. Generally, the people that are really acute obviously are panicking, so there's a big sort of psychological thing. They're panicking, they're thinking the life's over, they have to have surgery, whatever. A lot of the time, to try and calm them down, you almost try and describe the anatomy of the disc. So you've got obviously the fluid in the centre, so the nucleus pulposus for Google nerds like us, and pushes out against the fibres. You've got this big long ligament that comes right down the back, your posterior longitudinal ligament. Often all that is like a secondary barrier. So you've got normally the chronic disc bulges are pushing against that secondary barrier. The acute ones with the really painful, really sore, bypass that barrier, hence why you get the nerve pain, the sort of agony that comes with it. From that point, your body's in a bit of a rush to heal, to settle down. So these people you always end up with who are really acute and really painful, I generally try and reassure them by basically explaining the full, bit more explanation than what we've just done there, but try and explain it all to a point of it. Normally, if you're in that much agony to start with, the healing process is considerably quicker than someone who's chronic, who's sort of staying down here. It's like a low mundane pain that sort of stays at that level. Whereas your acute pain starts up here but tends to drop quite considerably quite quickly if you're dealing with it in the right way. And from my personal point of view, I always think, I don't know about what you two think, but I think a lot of back pain is just sheer reassurance a lot of the time. You were designed to heal at the end of the day. You spoke about scabs and stuff before and cuts. It will heal eventually if you do the right things. Our job is to accelerate that to its best degree and reassure the person along the way.
Do it safely.
Safely, and I think a lot of that, if you can just get someone to relax a little bit, so it will be okay, it will be fine, we've just got to do X, Y and Z. A lot of the time, you can physically see it on them, can't you, sometimes, where they just go, all right, I trust you, it's fine.
And it's your expectation as well, isn't it? Like, which is related to that education. It's not like, depending whether it's acute or chronic, it's not just going to go just like that. If it's chronic, it's probably been building up for months, if not years. So it's kind of getting to the bottom of that and also correcting what's caused it. And your acute is obviously, you know, if the pain is through the roof and they're not sleeping and, you know, that's horrific pain, it boils down to your first priority is your pain management. So whether that is like medication and speak to the GP about, and in terms of like most of the time, it's like we manage it, don't we, with manual therapy, with staged strengthening or mobility, but it's more rare that it's going to be surgery, you know, and again, you know, rare again, injections, but it's on the whole, it's quite easy enough to manage, isn't it? It's just your time frame differs for the individual.
Well, that's, yeah, so basically what the big evidence is education is a massive one for lower back pain. Like, you know, there's been countless studies that showing that education with all sorts of back pain and trying to help people understand that. I suppose, like you said, that reassurance is that famous Louis Gifford quote, like reassurance is a painkiller, and it is true, helping people understand that, and but also like with sciatic type symptoms, these chronic, these acute sort of nerve conditions. Understanding that, you know, I've talked about before about expectations and reality. That after 12 weeks. 50% of people have resolution. So while it might go down quickly, that's actually 1 in 2 people after 12 weeks will be pain-free. So obviously that shows that 50% of people will still have it after 12 weeks. Yeah. And then after that, there's 25% that will actually still have it after 12 months. And then you've got other. So it's helped people be face up to any sort of fears, but also you can be realistic as well and reassuring at the same time. You're trying to get the right balance, and like you said, understanding and put difference. Like sciatica is an umbrella term for sort of that sharp pain which we call radicular, or that kind of pins and needles which we call radicopathy. And understanding, well, you might have a bit of both or one or the other, and then how we get through that and sort of build through that process. It's massively important, and just miss, I think, you know, there's so much stuff around backs, like you say, you know, I need an operation or injection, or it's a donut, or I've got a prolapse disc. I mean, again, you know, education-wise, the studies with men over, I think it was men between 50 and 60, I think it was, and like, I think half of them had some form of degeneration within the back. So, you know, they get an x-ray in the back and say, oh, well, there's degeneration there. Well, yeah, but that's like saying you go grey or you get wrinkles. These are normal changes. Yeah. So it's helping people understand. And again, people with like disc, you know, well, I've got a prolapse disc. Right, okay, but that doesn't always mean that. Yeah. There's a lot of people walking around with prolapse disc actually without any pain, because like you said, it's not touching those structures and not causing any, you know, effect. And the acute one, you know, that's really common because your nerves are getting sort of pinched and pulled all the time. So and it's understanding those processes. One of my favourite words is axoplasmic transportation. There you go. Sounds like a good band. Sounds like a good band, but it's understanding actually that's why people do something on the back, like go into the garage, and then like a day or two later they get the pain, because it's a different system that's going through. So the sort of like the inflammatory cells and stuff take a bit longer to release. So explaining it again, that's just part of the education, why you can get very sharp, very sore, or it could take a few days to come on. But the key thing is going back to your original point, which was about moving. No matter what you do, you got to move. And I forgot his name, the guy in Australia, but he had a really technical term for getting moving. I think he called it, because he said he spoke to a surgeon once who said, well, it's not a vascular area, so you need to get air and blood into that to allow, try and get some heal. So that, I think the technical term was you got to jiggle and wiggle it, I think is what he said.
Yeah, very technical.
So I have to tell people to jiggle and wiggle and walk loosely again.
Yeah.
Louis Gifford, he said when you're in pain, you walk with thoughtful, fearful movement. So you become really stiff. I have to just say, well, you need to become thoughtless, fearless, which is what he says, but I say that quite loosey-goosey, for that jiggle and wiggle, you need to walk loosey and goosey, and just by doing that, by breathing, by relaxing, by, again, another term, making friends with the pain, it's not that scary dog over there, it's just a dog who barks. You can, that just straight away, you can try and gain some, it's about gaining control, and you're not managing that pain, you're not going to get rid of it. You've got to put things in place, like Pete Moore from Pain Toolkit talks about self-management, pacing breaks, all these little things. You've got to just, there's some really good information out there, and we're sort of really lucky to use it, but you just put really, really simple things in place from education to management, and that is generally the best way forward.
Like you say about the movement, it's like how many times have we had where my back's in agony and I'm bedbound, and it's like, we get that you're bedbound, but your pain management's not under control, but we need to move to some degree. Exactly. And you're getting a lot of that secondary pain, not from the actual injury, but because your body's seized up and because you're not moving as well. And I don't know if you've like how much you've seen it as well clinically. Like I know I see it quite a lot, but just the link with other things that affect lower back. So, a lot of people with like the IBS general term or sort of bowel stomach things going on, and the back is, goes through these flare-ups, but it's because something else is going on. So we understand that, we understand those patterns of what's your norm, just lower back, or is there something else within that pelvic cavity going on as well, whether it be the stomach or the reproductive system. It just doesn't add up, and there might be another reason as to why they're getting that back pain.
So one thing, again, just touching on the education side of things that you were talking before, when you spoke about like people wander around all day with disc bulges, prolapses, whatever, without any pain. One thing I always try and almost ram down people's throats sometimes when they talk about going for a scan, which is great, fine, great that we've got that technology out there. They'll go for whether it's MRI, ultrasound, whatever it might be, it's being able to interpret what the results say. Yeah. So every MRI scan I've ever seen, big long list of ailments, and we're all dying. We've got all these things. It's being able to clinically reason what the actual issue is. If you've got 10 things, whether it's narrowing foramen, disc pathologies, compression of L1, L5S2 nerve, whatever it might be, that generally comes up quite a lot. Degenerative disc disease that people always seem to
forget.
Comes
out in Latin, so
literally,
it scares them. It
scares them, and I always say the same thing. If you want me to interpret it, let me know, because a lot of the time they read it and they just go, right, I might as well give up on life and not do anything. Where realistically, there's probably only one thing in there that's actually contributing towards your pain. The rest of it is completely asymptomatic, and we don't have to worry about it. And I think it's important that people look at scan results, is understanding what you're going looking for. You're not trying to find something that's not there. We're trying to understand.
Is that the reason for your pain?
Exactly. What within that scan result gives you the discomfort, and then we can move forward with it. I just think people are too reliant on, here's my result. It's like, right, well, it's great, we've got that information, but let's actually implement it properly now, And again, it's just that educational thing again, isn't it?
Yeah, massively. And I like obviously another big link between depression and lower back pain.
Yeah, absolutely.
So we know that the research shows us that. So we just got to consider, and then we come into the realms of the buzzword that's around. Got to get it. Biopsychosocial.
Oh,
yeah.
There we are.
Favourite model.
So again, it is a buzzword, but again, sometimes therapists forget about the biology and concentrate on it. Yeah. But it's recognising, we need to do it for lots of conditions, but certainly with backs, we need to sort of consider, right, well, so my favourite phrase is, what's the issue with the tissue, but what's the problem with the noggin? So we need to look, is there a link there? Is there something going on? Right, okay, you are a little bit weak there, but you've also got a lot of stress going on. You've got a lot of external pressures from work, from family. You're not able to do what you used to do activity-wise. So let's build that back in. Let's create some, a word that people use a lot nowadays, well-being, but it's all self-care. These are kind of buzzwords, especially on social media. But just do something, make sure you're putting those like real pressure relief valves into you. You don't have to do anything crazy, but right, 20 minutes here, 20 minutes there, doing this a bit differently, just change that up. It takes work. I mean, it's not, I think that's the other thing with these things, especially whether it's a long-standing chronic back pain or it's or persistent sometimes, it can also be called, or whether it's acute, putting things in place, working hard, that'll get you to where you need to get to.
I think that's a really good analogy you've used there, actually, press release, because I'm terrible at doing this. You know, I basically work to a holiday, do you know, that type of thing. I wouldn't have a day off for the sake of having a day off, or a morning off for the sake of having a morning off. But actually, that would probably be really beneficial, just them couple of hours here and there, do you know, like, or have a morning doing admin stuff for the clinic, do you know, and I think a lot can implement that into their life, whether it is training, exercise, taking the dog for a walk, having a couple of hours off, do you know, a weekend away, you know, that type of thing. I think we all fall into that rut sometimes, don't we, of just squeezing your week as best you can. But just like I said, that little press release that you're on about, it does take the sting out of things a little bit, doesn't it?
Small mercies, isn't it? So you find those little things that even, so it could start, you know, it could be just 5 minutes with a brew, you know, listen to this podcast maybe, I don't know. And then,
obviously, everyone's
or just having, you know, going for a walk, just 20 minutes, you know. I think, again, you can, that's the psychology part of it as well, but other psychology can be that you're struggling psychologically, but you can psychologically think, I can't do these things, and you've got to think, right, okay, where can I put these little moments, you know, it's not about being, say you've got to train for 3 hours, it's like, can I do something for 5 minutes here or 10 minutes there? And then this, you know, obviously the social pressures, or if it's something that's good socially, can I do that, you know, once a week, or you know, maybe try and meet with some friends. I mean, but you know, like there's have you heard of the running granny? She's so she is a really interesting lady. She's just done the spine race. She did 104 hours.
How old is she?
I'm going to say 60s, but I might be wrong.
Okay.
But she was a doctor, and really, but before that she worked in a completely different industry. Really interesting lady. She taught us on the masters for a session and brought in that's still what work. Brought in a real skeleton.
Oh, okay.
Yeah, just carrying that around with her. She's really, but she's on social media. She look her up, running granny, fantastic lady. But she was talking about how she got into that at one. I think some things happened to her personally. She had like sort of social work, you know, family pressures, you know, work pressures. But all she just did was like every day we just run, you know, run for or get out. No, but not was it. I don't think it was even running. Just get out 15 minutes a day. So you could think you can't have the time, but do you? Because you know, I don't have the time. But then you spend half an hour on social media flicking through.
Well, that's
so
it.
So you've got to find those. I think why we're saying that with back pain, whether it's chronic or acute, you have to find that time and to be able to put stuff in place. It does take work. Like I have back issues. I've had them for like 10, 12 years now, and I have to put things in place. And one thing I have to say to people, if it's going to be something like that, you might have it for the rest of your life, which, oh my. But actually, again, let's just front up, let's get the facts, and then actually you can manage it. So you might have episodes where it's worse, or might have periods where it's a bit, but actually, over the time, you're able to sort of manage it better.
And I think with spines as well, more probably than other areas in the body, we're big advocates of your strength is your priority over your stretch. But obviously, it's your movement in your spine, your mobility in your spine. That's key for the spinal health as well. Obviously, we do need to load the spine. It's not weak, it's robust, but we've got to definitely prioritise time for that mobility of that area as well. And obviously it does need loading. We need to work on those smaller muscles as well as those bigger muscles. And just sort of technique correction as well. It might be that, you know, they're going to the gym a lot or they're not going to the gym a lot, but when they are doing exercises, we might just need to tweak what you're doing, because that way you're doing it, you're quite weak and you're training in that weak area. So you're kind of making your weaker sides weaker and your stronger sides stronger, but it might just be that they just need a few cues as to what they're doing wrong or why they're doing it wrong and why it would be better. And obviously spine shapes, they are slightly different per individual. You know, they might be slightly more lordotic and that's normal for them. So they might be a little bit more inclined to be quite glute, and hammies can switch on as happily as they can, but the quads are a little bit more of a a deficit. So, but it's their norm compared to someone else who might be a bit more like, you know, not as sort of, those angles aren't as large for them. So it might be that what they need is slightly different as well.
Let's do some myth busting.
Okay.
Because there's loads of myths around backs, isn't there? So obviously people generally come into clinic and they've Googled something. I've seen
Dr.
this.
Google.
Dr. Google. I've tried this, I've done this. Dave told me to try this because it worked for him. So I'll throw this at you first because we'll go down the line. What myth do you get a lot of? Like what would someone say to you, oh, I've done this, and you know it's not going to work?
What, from the back point of view?
Yeah.
It's out of alignment.
Oh,
That's
cringe.
If your back's, if your back's out of alignment, you
My hips are
probably
twisted.
you need to go to
Funeral directors.
A&E.
Okay, not far off.
Oh yeah, there's one across the road at Lille, isn't there? So,
Yeah, there you go, straight in. So yeah, spine out of alignment's a common one. And or they tell you the opposite way around, or someone put it back in.
Oh God.
Someone
Yeah,
put it back
can't
in.
cope with that.
Just for the record, and I'll look at the camera when I'm saying this, your spine doesn't come out of alignment. Right? It's so
Robust.
it's so densely compact and squashed in with some of the strongest ligaments in your body, some of the strongest muscles in your body. It is nigh and impossible for your spine to come out of alignment. So
also, as well, how can my spine get out of alignment, but no other joint can?
Exactly.
I know. I know. Can you put
Very
it back in?
specific.
That's what amazes me. Or someone put it back in for me.
They did a big clunk and a click.
They didn't at all. So that's actually my myth. So we'll go on to that while we're at it. So the clunks and the clicks.
Yeah.
Sort of touching on what you're saying there. Clunks and clicks aren't things going back into place.
It's
a
normal.
Release. It's normal. It's a release of negative air pressure. So we could probably do it with your fingers, can't you?
Try to
No?
do it. You never
Just
do
a
it.
little time.
don't.
I can
Not
never
on
do it. You
demand.
try and show someone.
Not on demand. I
Including.
normally do it, but they're not. Yes, your fingers do it, don't they? And it's just, there you go. It's purely negative earth pressure. You get a big spark of endorphins, don't you? You feel great for a few seconds, and it comes back pretty quick. And it's Robert's just clicking his fingers there.
But also as well, like you've got not just your back, but you've got receptors, haven't you? So you think your mechanoreceptors around those ligaments and those joints. So it will, it will feel better because it's just, you say there's been a change, like I said, with the endorphins, but there might be a slight change in the stress in them, and that can just make it feel a bit better. But that comes back to your point about moving, doesn't it? So I always talk about 2D and 3D. So when you've got someone that can only work at a very short level, they can't move that far. Yes, our goal is to get it to be lengthened, but through the movement and the strengthening, we're then going to make it 3D so they can move in different planes of motion. So you're not just going up and down or side to side, you can go diagonally and other stuff like that and load it under that, which then goes back to the other point again about strengthening the weak areas and lengthening the tight areas.
And I think what's very social media happy is these videos that go viral of someone being clunked and clicked from head to toe, and it kind of grosses some people out. Yeah. And it's like, wow, I feel amazing, and it's literally like you said, short-term receptors and boost, and it just doesn't change your body. It doesn't change your alignment. It doesn't slip you back into place. We do, in terms of joint movements, we work on them and you glide them and you mobilise them in a certain way. And we have a grading system of 1, 2, 3, 4. Your 1 to 2 is to sort of improve or decrease sort of your pain receptors and to just slightly trying to get that sort of movement going on. But your 3 to 4 is when you move and mobilise them joints.
It's just helping the body. Yeah. The role of us is not, we don't fix people, just try to help people get a little bit, if there's a bit of fear around that movement, if there's a bit of, I have to, again, talk about analogy. I use you roll your ankle, you limp. There's protective muscle spasm around that to keep the joint stiff to protect it. Same with the back. Have an issue there. A wide area spasms up, stiffens up to protect it, but then it becomes sort of a disproportionate reaction, especially if it's chronic. So it keeps having a wide spasm and muscle guarding. So our job is to tell the body, actually, you can move a bit more. And then that norm, which you said before is narrow, becomes a bit wider, and then eventually becomes 3D.
But you also need to, like when we've worked on areas, you need to, like a big key of what we do is looking at the cause behind it. So it's not just a quick fix, it's like what's happened and we get to the cause of that and the biomechanics so it doesn't happen again, it doesn't reoccur and come back.
One thing I always said to people is, I've used it this morning actually, as long as it makes sense, I'm not bothered. As long as your symptoms, your subjective, the onset, and what you're describing and what you're presenting with all match up, I don't really care, because we know what we can do to get on top of it. So as long as it makes sense, I don't care, because you know then where to go forward with it. It's when people present with sort of slightly strange symptoms or symptoms that don't seem to match the subjective, or something that's a bit out of the norm, which you look at referring on, or you refer for, or then you sort of start speaking about MRI scans.
Yeah, exactly. That's something we'll always do, don't we? Look, it's in our industry, it's called red flags, isn't it? So we look at those red flags as, because, some of these conditions, some of the back pain conditions can be somewhat more sinister. It could, obviously, the obvious one being cancer, but it could be a few other variants, rheumatological, rheumatology, other things. So that's where, and we've got knowledge and experience around that, and so we'll always keep an eye on that if anyone comes in.
I think we're quite good at that as well, in terms of, again, going back to that the strain, the backlog on the NHS. We know that sometimes things just don't add up, and if they've been referred for bloods and it's fine, we know that it just doesn't make sense. So we're quite keen at you need to go back, you need to be seen, you need to be heard. If you've got the option of private healthcare, if that, wait list is 3 years for that, but you're still struggling with this, and it just, we just know when something doesn't make sense sometimes, don't we?
Any other myths?
Come on, Maz, you've not given us a myth yet.
You're putting me on the spot now.
Hard floors. Lying on a hard floor. You don't hear it much anymore. Have you never come across that?
No.
Get out, you've never heard that? So I've had it quite a lot, but it's not something that, it's quite an old thing people used to say. If you've had a back issue, or I've slipped a disc and all that rubbish, lie on a hard floor. And that genuinely was like a passive treatment method people used to do. They wouldn't sleep in bed, they'd sleep on a hard floor. And do you know what? It didn't work.
What it does is, it's like anything, it's something a bit different. Yeah. So when mine was really bad, when mine's bad, sometimes lying on a hard floor will just give me some temporary relief. But again, it's the context, isn't it? Like you said, and historically, it would have, like 30, 40 years ago, when my GP told me to lie, and so I did. I slept on a hard floor for 3 weeks. And is that, well, yeah, but it's also probably got better because it's 3 or 4 weeks down the line. Yeah. I think, like disc popping out, slip discs, that's another one, isn't it?
They don't slip.
The disc,
Yeah.
there's no slippage there.
I have to say, because of my, obviously, foot background and biomechanics, I cringe when they say, I've got your Joe blogs, I've just got a trainers with an arch support. I'm like, right, okay. Why? Dunno. Like, I went on a treadmill once and someone told me that I needed trainers with an arch support. I was like, right, let's look at your feet. And it's important to understand that you are an individual. Your right foot might be different to your left foot. So your right foot might need some support, your left foot might not. You've got a lot of muscles in your feet and your lower legs that you might not need that, because you could just do certain exercises and they'll improve or respond to. But you've got so many joints in your feet as well. And it's like, the ways our body's designed is to tolerate stresses and loads and to move in certain ways. Feet should be able to move. A lot of the time I found people will come in and they've got insoles in the shoes and they're hard and they're rigid. And they've come from, a podiatrist. And I think, why I don't understand why this is appropriate for you, and you're an active, mobile person, and that part of your foot is now restricted, it can't move. And it's like, you need to take into account your forefoot, your midfoot, your rear foot, and you,
Also then how that affects your back then, isn't it?
Exactly.
So that is important. And maybe, we'll do a foot and ankle special as well.
But one thing to take on from that is I'd always recommend a neutral trainer.
Love a neutral shoe.
Do your foot intrinsics, your lower leg strength. Most of the time it will help. If it doesn't, then you might need
That's why the own clouds are quite good, aren't they? Because they're Swiss.
We'll end on that.
That's a good bombshell there.
Good
That rubbish joke.
Thank you very much.
Thank
Thank
you.
you.